In Tune. Conversations on audiology and balance. An Inventis podcast.
Welcome to this new episode of our podcast dedicated to balance. Today we have the honor of hosting Professor Enrico Armato, who has 37 years of experience as a hospital ENT specialist, over 30 years of passion in the vestibular field, is a contract professor in the Department of Neurosciences at the University of Padua in Italy, and holds a Doctor of Philosophy from the University of Lorraine in France. Enrico is a highly experienced figure in the field, and he will guide us through the discovery of the video head impulse test, better known as vHIT. Together with him, we will explore his professional journey, the clinical value of this test, and its role in the diagnosis and follow-up of patients. Good morning, Professor. How did your interest in the vestibular field begin?
Thank you for your kind invitation. It is a real pleasure to be here with you today. My interest began 30 years ago when I heard a presentation by Dr. Enrico Armato at a vestibology conference in Paris. The innovation of his content and the clarity of his presentation were astonishing, and I was fascinated. The following year, I went to visit him in Marseille and saw him at work in his professional practice, known in French as a cabinet.
Wow, could you describe his practice, which is called a cabinet?
God, I have to tell you the truth. First of all, the most remarkable thing was the location. Eric was in Marseille and had a view over the Vieux Port, that is, the old port. It was incredible. You would walk in and see this expanse of sea with boats and Notre Dame de la Garde in the background. Then there were rooms and rooms full of instruments and equipment. The patient would practically change position, if not for every test, then almost every time. Honestly, it was a truly unique experience.
That's fascinating.
So I was struck by it, and that convinced me to purchase my first video nystagmography system. From there, a deep friendship was born, and we started seeing each other regularly, first in Marseille and then in Cannes when he moved there. I learned a great deal, and I have to say, I consider Eric my true mentor, my guide, my beacon in the world of neurotology. From how to approach the patient, how to perform a test, the tricks and interpretation, and not least, the relationship with the patient, because the relationship with the patient is fundamental. Unfortunately, Eric left us too soon in 2011.
You were a great friend of Dr. Enrico Armato. Can you tell us something about this friendship and how it influenced your clinical perspective?
Of course. What always struck me about Eric was his scientific expertise and his great humanity. His knowledge of computer science was such that he was able to write the first version of the video nystagmography software in DOS language, whose pupil-centering algorithm had been created in collaboration with the French CNR. His humanity was expressed by the great helpfulness and kindness he showed to everyone. He also had a great sense of humor, always telling British-style jokes with a great sense of self-deprecation. We shared numerous conferences where his generosity translated into a substantial exchange of information. We published articles together, and I was his guest on numerous convivial evenings because Eric also loved and appreciated good food.
Is there a conference that you remember with a smile, one that particularly struck you together with Dr. Enrico Armato?
Of course, I remember his invitation to the meeting of French video nystagmography users in 1999. We were in Marseille, and I was very excited because I had to deliver a presentation and was the first to speak in the afternoon. There was lunch, and then the sessions resumed. I remember perhaps having a couple of extra glasses of wine to help me relax.
I imagine it was a very interesting moment of sharing.
Yeah, beautiful, just beautiful. There were also many prominent people there. I'll mention one name for all, Georges Frese, Professor Georges Frese, who is the one who gave his name to the Frese scheme, which is used to express the values of BITM calorimetric tests.
Speaking a bit more about the part related to exams, I'd like to shift now to your daily life in Italy. How is your work organized in your practice, and what are the most common exams in your daily routine?
Certainly. So being a freelancer, which is what I am at the moment, gives me a lot of organizational freedom because I don't work in a multi-specialty clinic with other colleagues, but in my own private practice. As a result, I have complete control over my schedule, and I try to accommodate my patients' needs. I should mention that it's not uncommon for me to work even on holidays, especially with patients I've known for a long time. This is because the relationship between doctors and patients is very important.
Of course, this clearly demonstrates a truly great passion for your important work.
I also have an agreement with the University of Padua Department of Neuroscience, and this means I always have internship students from the Audiometric Degree Course. This is a great motivation for me because I really enjoy teaching, and it's wonderful to see passionate people. Returning to the main topic, the process for patient visits follows some fundamental steps, such as collecting the medical history, that is, describing the symptoms and how they have evolved. Then the clinical vestibular examination under the video nystagmoscopic mask, and finally the video head impulse test. Of course, the process is then tailored to the patient and the diagnostic suspicion, so VNG with oculomotricity, caloric and kinetic tests, bithermal, cricaloric tests, Bell, and vestibular evoked potentials may come into play. Naturally, since it's impossible to predict the extent and duration of the assessments, it's not uncommon for me to have the patient return soon after to complete the process. Everything concludes with the drafting of a detailed report, which I remind you is a mandatory act in the medical profession.
So you consider the symptoms very carefully, but also the patient's history in order to make an accurate diagnosis?
Absolutely, yes. This combination is inseparable, and it is always the medical history that guides the diagnostic suspicion. In most cases, the clinical examination serves to confirm the suspicion raised during the anamnesis.
Fantastic. Thank you very much for these very interesting answers. It's clear that you have a great passion for the vestibular field. You were among the first to use the Synapsys vHIT in Italy. How have you seen this tool evolve over the years, and what role does it play today in vestibular diagnosis?
Thank you, Mario. That's a great question, and I'd like to digress briefly to talk about video nystagmography because I was one of the first people in Italy to receive a complete video nystagmography system. That was in 1997. I still remember the excitement when they came to install it in my office. The system was complete, which allowed me to gain extensive experience with all of its modules. The main features that have evolved positively over time have been its immediacy and ease of use in everyday practice, the abundance of parameters provided, which were always presented according to a hierarchy of importance, and the unsurpassed clarity of the eye position and velocity traces. Everything was truly customizable. Similarly, for the Synapsys vHIT, which was the question you asked me, I started using it more than 10 years ago. I have performed thousands of tests myself, and I have appreciated its unique features such as the absence of a mask on the patient's face, the binocular information on the horizontal plane of head movements, the gaze position graph, and not just the head speed graph. I consider it a fundamental test for the accuracy of information and speed of execution. In fact, I routinely perform it on all patients, except of course for classic forms of canal lithiasis.
On all patients?
Yes, Mario. Actually, I use it on all patients because its simplicity and completeness are two extremely strong points in favor of this test. I never skip it.
Thank you very much, Enrico. From a clinical perspective, how incredibly important is the video head impulse test in thoroughly distinguishing between a peripheral vestibular problem and a more central one?
Excellent question. Video head impulse test eliminates the examiner's subjectivity in interpreting the results. This is a considerable advantage, especially if the clinician does not have extensive experience. In a peripheral subject, damage to the vestibulo-ocular reflex circuit will be evident, with reduced gain and altered response morphology due to the appearance of refixation saccades. Central subjects will almost always show a normal vestibulo-ocular reflex. However, we must bear in mind that there are exceptions to all rules, and some central subjects show a positive video head impulse test like peripheral subjects.
Of course, there are always exceptions everywhere.
Absolutely.
Which specific vestibular disorders truly benefit the most from utilizing the video head impulse test as a comprehensive diagnostic tool for assessment?
Look, I would like to answer all of them, of course. There are many lesion patterns, and identifying them is extremely helpful for clinicians in the diagnostic process. As I mentioned, it is less significant in the classic patterns of canalolithiasis because it turns out negative.
I understand. Can you describe one of the most frequent patterns in the field?
Look, absolutely yes, and we're talking about vestibular neuritis, an acute form of vertigo. As we well know, it usually presents at the beginning in most cases as superior vestibular neuritis, meaning damage to the lateral and anterior semicircular canals. So there's a reduction in gain, the appearance of refixation saccades that change over time, and during recovery, these patients can recover completely but still experience subjective disturbances, just as there are patients who remain with the damage but subjectively feel very well. In the very first acute phase, there can also be apparent involvement of the opposite lateral semicircular canal, meaning the healthy side. This is due to a balancing mechanism at the level of the vestibular nuclei, which, however, recovers over time. The saccades start out mixed, covert and overt, and then the overt ones tend to disappear, especially as compensation becomes more pronounced, and above all, the latency becomes the same for all these recovery phenomena. So the patterns of vestibular neuritis, this model of vestibular neuritis, is also an excellent reference for what concerns vestibular rehabilitation.
Fantastic. So the vHIT can also be used during follow-up and even in vestibular rehabilitation?
Absolutely, yes. vHIT is an indispensable tool for monitoring patients undergoing vestibular rehabilitation. It allows you to track the patient's progress or sometimes regression and to modify therapeutic strategies accordingly. I have extensive experience in France, and I can tell you that in that country and in French-speaking countries, the specialist role of vestibular rehabilitation therapist or kiné is very widespread. These therapists work in pairs, in fixed partnerships with ENT specialists. Almost all physiotherapists are equipped with the video head impulse test device and use it regularly. I would also like to conclude by saying that it would be highly desirable for these specialists and the instrument to become more widespread here in Italy as well.
Thank you, Professor. What advice would you give to someone who is approaching the field of vestibology and wants to deepen their understanding of tools like the vHIT?
Great question. I'm more than happy to answer. As always, in these cases, first and foremost, you need a solid cultural foundation, which unfortunately can only be acquired through study and then, of course, with a lot of practice. There are no shortcuts. It's something you just have to accept. Another essential ingredient is a deep passion for the subject.
I understand that, in fact, practice is very important in many things. We have finished the questions, but to conclude on a lighter note, is there a curious anecdote, an unexpected episode that happened to you during the performance of a video head impulse test in your daily practice? Any story that you remember in a particular way?
Of course, Mario. More than anything else, it's an observation rather than a story, because it made me realize the importance of the approach to the patient. I'll tell you that once I had a patient whose vHIT was really unclear, and I was struggling to make sense of it. She couldn't give me a reason based on the clinical picture. So after thinking about it, I had the intuition to give the patient new instructions, to explain the whole test from scratch. And when I repeated it, miraculously, incredibly, I obtained a normal trace, as expected. This is because clinical reasoning must never fail, and we must never forget that we are dealing with people and therefore with something that must provide us with the answers we would like to have and not those we expect.
Thank you, Enrico, for sharing this specific case and highlighting the importance of the context that needs to be provided to the patient at the time of the examination.
Yes, look, I can tell you that in all tests, in any neurological test, the interaction with the patient and the explanation detailed, I would even say meticulous, are a guarantee of a clean exam, an exam that is easier to interpret, an exam with a lot of signal, meaning information, and very little noise, meaning things that confuse.
Thank you very much. We sincerely thank Professor Enrico Armato for sharing with us his experience and his vision on the use of vHIT in daily clinical practice. It has been a valuable journey through history, clinical applications, and future perspectives. We invite you to stay with us for the upcoming episodes as well, where we will continue to delve into key topics for the diagnosis and management of vestibular disorders.
Thank you. It was truly a pleasure. Really, thank you again.
Thank you very much, Professor Enrico, for being here with us.